Good afternoon, everyone. Welcome to the Henry Schein Dental Academy webinar series. My name's Adam, and I'll be your moderator. We're excited to welcome back Dr. David Wong as our speaker, and today he'll be reviewing implants in the aesthetic zone. Today's webinar is also sponsored by Planmeca. Per usual, if you have any questions, drop them in the Q&A section, and we'll get to them at the end. And we are not offering CE credit for viewing or attending this presentation live or on demand. Over to you, Dr. Wong.
Adam, thank you so much, and thank you everybody out there for taking the time to listen to me speak again. So anyway, today we're talking about CBCT in action, which has kind of been the theme for us for a while now, but we're going to focus on implants in the aesthetic zone. And today we're going to see a mixture of some of the cases that I've showed you guys before previously, but we're going to expand on some concepts for those of you who either place or restore implants in the aesthetic zone. So we're going to go over some tips and some guidelines to hopefully, number one, keep us out of trouble, but number two, give us the best result possible for patients. So let's go ahead and get started. As you guys may or may not know, I've got a couple of Instagram accounts. First one is my main one. It's david.long.dds. The second one is kind of more surgical and involved, and it's Plaque China. So join me there. It's also where I keep in touch and give you guys notices on when we do webinars like this. Also, when we do live courses and other courses or meetings that we may be involved with. So the name of the game today is implant aesthetics. So what we're going to be talking about is how, from start to finish, from a hopeless tooth or maybe an already missing tooth, how do we get it to look good? How do we get it, give a patient their smile back that they're going to be proud of, that they can function and eat with, and be proud to show off to their friends and family? How do we do that? Just as a resource to you, I do want to point out some of these concepts that I'm going to be talking about today are in my chapter in Implant Aesthetics, which is a textbook that's edited by a good friend of mine, Dr. Dwayne Caratu, who's at the University of Illinois in Chicago. He's the perio chair there, a great guy. As you can see here too, there's a lot of other names that you'll probably recognize as well. So another meeting that I'm going to be excited to be presenting at, I'm actually giving two presentations here, is going to be at Henry Schein's Thrive Live 2022. It's going to be in Las Vegas on April 7th through the 9th. The website's there for you to peruse and register. Hope you guys can make it out, and then I'll talk to you about some other opportunities to come get more information if you like what we're talking about today. I'm going to give you another link to some meetings where you can see this live and in person as well. So what we're looking at today is, once again, where's the implant? If we're doing our job right as dentists, hopefully we can't really tell where the implant is. So in a situation like this, I've showed you guys this slide before, and if you're new to this type of information, I'm going to tell you the implants are number 6, 8, 9, and 11. But how do we get to this point? How do we train the tissue and grow the bone to where we can place the implant where we want to place it? This one right here, where's the implant? It's tooth number 8. So once again, it doesn't matter if we're taking the tooth from start to finish, from an extraction to the graft to the implant to the restoration, or if we do it all in one appointment, if we stage it or do an immediate, the concepts and principles are going to be generally the same. We don't want to get into a situation like this, where's the implant? Of course, it's tooth number 9. Now, the patient has a high smile line, and this is one of those cases where you just kind of shrug your shoulders. You don't know what to do with something like this. This is a photo that was sent to me from a referring doctor from out of town, and he was wondering what we could do to help recover. Unfortunately, I saw the patient one time in my office and never saw her again. This is a patient referred to me by a periodontist. So it doesn't matter if you're a general dentist or a periodontist or other specialist. We're all prone to making mistakes in the aesthetic zone. So today is all about keeping everybody out of trouble. And then later on, we'll talk about some other concepts. I've got lots of webinars lined up for you all with Henry Schein. So we've got lots of concepts that we can build on. So the question today is going to be that we're going to start off with is, what do you do with an implant? With a tooth like tooth number 9 here. It's a hopeless tooth. Patient's dad's a dentist, so he's very dental. His dental IQ is pretty good. what do you do? We have a lot of questions that we're going to go through here. What about this tooth here, number 8? It's got a fistulous tract at the apex. The tooth is hopeless, but the gingival margins are all, uneven. What do you do in that situation? Are you thinking an immediate implant, immediate placement, immediate restoration? What are you thinking? What about this tooth? This tooth has, 1 to 2 millimeters of gingival recession already. It's also a hopeless tooth. There's bone loss on the distal aspect. Once again, how do we approach these types of cases? How do we evaluate the aesthetics and determine how difficult of a case this is? So maybe, you might want to, if you're a general dentist, maybe you want to do it. Or if it's too difficult, maybe you want somebody else to do it. So how do you determine that? And that's what I want to show you today. The questions we should be asking ourselves when we have these types of cases is, number one, how do you extract the tooth? Is it okay to use a flap, for example? Does it have to be flapless? What are the tools and things like that that you need to have to properly extract the tooth? Number 2 is, once the tooth is out, do you place an implant at the same time? Does the design of the implant matter? Does it have to be tapered or straight walled, or what's the thread design? Does that matter? What about the implant position? A lot of times I'll hear dentists say that they tackle front teeth because they're single rooted teeth, and you just take the tooth out and put the implant in the same spot. Is that the right spot though? Number 4, now that you have the implant in, it's going to be obviously skinnier than the socket. Do you put a bone graft, in the gap between the implant and the socket, or not? And if so, what type of graft do you put in there? And do you have to use a membrane? There's a lot of questions that we have to talk about. Do we need sutures? Are those important? What about a provisional? How do you know if an implant's stable enough to go ahead and put a provisional on? What about gum grafting? When would you not utilize gum grafting to really, fill out that facial contour on an anterior tooth? So these are all questions that we need to answer. Other questions that you're going to want to talk about, and I think the most important question, honestly, is if you guys are new or semi-new to implants, the question really is, do immediate implants preserve the dimensions of the socket? That's the biggest argument for doing immediate implants, outside of saving the patient's time, of course. But that's really what everybody says. Do an immediate implant so the gums don't shrink, or so we maintain the bone before it has time to resorb. But is that true? We're going to talk a little bit about where the implant should properly be placed, and of course, talk about the graft materials and that type of thing. So we're going to also look at the difference between placing an immediate provisional versus just a healing abutment. So what are the differences there? And I'm going to hit you guys with a little bit of science. And the first thing that we got to consider is, when you take out an upper front tooth, the question we need to be thinking is how thick are the facial plates around these types of teeth? That's really it. So if you take out number 9, how thick is that facial plate? Well, why does that matter? It matters because, generally speaking, if they don't have a facial plate, you don't want to be doing an immediate implant. So if they have thin bone, then you got to kind of sort of consider it. So one of the things that you're going to notice when we look at some of these studies, this is a pretty popular chart that you'll see in several people's presentations. But what happens is, when you take out a tooth, they've done these studies where they look at the thickness of the facial plate, and you're going to notice that 87%, I'm sorry, 80, we're high 80s. It is 87% of all facial plates are 1 millimeter thick or less. Okay, so that's almost 9 out of 10 of front teeth have facial plates 1 millimeter or less in thickness. So we run a high risk with most of these front teeth. Matter of fact, 64% of these teeth have facial plates that are 0.5 millimeter or less. So they're really incredibly thin. So I want to introduce you to, or get you acquainted with, how we categorize sockets, not for extractions and sockets. That's a different presentation. We're talking about sockets when we're talking about, considering immediate implants. There's 3 categories that Dr. Dennis Tarnow talks about. Type 1 is where you have both bone and gum tissue present, and they're at normal heights. Okay. That's easy. If you have bone and you have soft tissue, do an immediate implant. No brainer. Type 3, you have no bone and no soft tissue. Well, that's also a no brainer. You got to take the tooth out and then build it up separately and then come back later and do the implant. Type 2 is where everybody starts scratching their head. That's where you can make some mistakes. The problem with type 2s is that the gum tissue looks perfect. The tooth looks perfect. It just has to come out. The problem is that even though the tooth and the tissue looks good, there is no buccal plate. And that's a trap. That's where we get trapped. So let's start looking at this. So where CBCTs come in play, this is the only way that you're going to be able to determine if you have a facial plate. So a class 1 here, this is my friend actually, who's his dad's a dentist. Soft tissue looks great. It's perfect, pink, healthy, et cetera, et cetera. And on the CBCT, you can see that he has a facial plate. So in that situation, we went ahead and did an implant. That's a no-brainer. This is a class 2. Okay, so here the soft tissue looks really, really good. But if you look at the CBCT, there's no bone. And this is where we get, we're like, I want to put an implant in. There's just no bone to put it in, and this is hard too, because patients don't understand. They just look at their tooth and they're like, there's nothing wrong with the tooth, just put an implant in. So this is where CBCTs really tell you the whole story. This is that no-brainer, another no-brainer I was telling you about. The tooth has 4 millimeters of recession on it, and there's also no bone. So in that situation, you have to phase out your treatment. You have to build up the bone and soft tissue first before you place your implant. Next question, major question we got to ask ourselves is how much bone is lost after an extraction? This is an important question because it's going to determine whether or not we just take the tooth out and just leave it to heal, or do we take the tooth out and also graft the socket? Most of you guys who know me know the answer, what I'm going to say. But let's look at the dimensional changes of an extraction socket. So if you were to take out a tooth, front tooth, you're going to notice that within, according to these studies, on average between 4 to 6 months, you're going to lose about 1 millimeter to 1.5 millimeters of vertical bone height. And then you're also going to lose anywhere from 2 to 4.5 millimeters of ridge width. That's a lot. And a lot of people are like, well, I don't see that in practice. Now, one thing to note about these studies is that they reflected a flap to take out these teeth. And when you take out when you open a flap to take out teeth, you're going to lose more bone. And that's kind of the guideline here is to try to remove teeth flaplessly if you can, because you'll lose a lot less bone. But if you must, like I said, we're going to talk about bone grafting products today and also in the future as well. The next thing we got to talk about is, let's just say you got good soft tissue, you have good bone, and you want to put your implant in. That's fine. But after your implant's in, you have another decision to make. Do you just put a cover screw on? Do you put a healing abutment on? Or do you put a provisional on? Those are the 3 decisions that you have to make from a restorative perspective. But then you also have to make the decision on, well, there's a gap, between the bone and the implant. Do I put anything in there, or we just leave it alone? You're going to get a lot of different opinions on this, but what I want to share with you is the study from Dennis Tarnow. So I'm going to go, if you look at the bottom of your screen here, you're going to see no BGPR. Okay, that means no bone graft, but you do a provisional restoration. PR means you do a provisional restoration. BG is you do a bone graft, and then the 4th category is you do a bone graft as well as a provisional restoration. Now, on the far right, you're going to notice your bone loss. Okay, so your average bone loss for most of these patients, if you don't do a bone graft and you only put a provisional on, you're going to lose 0.8 millimeters. Okay, you're going to lose 1 millimeter. If you put a provisional restoration on only with the bone graft, if you just do a provisional restoration, you still lose about 1 millimeter, 0.7. So the key is your last 2 categories. If you put a bone graft and a healing abutment on, or a bone graft with a provisional restoration, you only lose 0.1 or 0.2 millimeters of bone. And we're talking about buccal lingually. So that's the key here is the bone graft. The best is if you put a bone graft, take out a tooth, put an implant in, the best result for minimizing the amount of bone loss that you're going to have around your implant, and I misspoke earlier, I meant crestal bone loss, by the way, crestal bone loss, not buccal, crestal bone loss. Your best results are going to be if you put a bone graft with a provisional restoration or a bone graft with a full contour healing bone. Those are your two best ways to preserve the bone. Okay. Now, what about patients with gingival recession? So I've shown you guys a couple of cases already where you take out the tooth, but the tooth is already previously preoperatively has gingival recession. What happens there? So what you need to know about that is when you take out, when a tooth already has 2 to 3 millimeters of recession, just know that the dehiscence underneath the soft tissue is almost twice that. Okay, and that's what you need to know. So if you're taking on a tooth that already has recession on it, you can pretty much count on just telling the patient that they're probably not going to get an implant that same day. Pretty easy, pretty easy diagnosis. When it comes to implant aesthetics, there's 4 guidelines that I like to go by. There's 4 factors that affect implant aesthetics, and this is written in a paper by a good friend of mine, Dr. Leonard Cooper. Number 1 is the existing gingival levels. So once again, what does that mean? It means if you have a tooth that already has recession on it, the existing gingival levels kind of dictate that your implant's going to have a long tooth unless you do something different. The implant depth, how deep you put the implant, is going to affect what the crown looks like. The response of the tissues to your implant procedures, such as your surgery and your prosthetics, will affect how things look. And this is really important because some patients have things in their medical history or their habits that prevent proper healing. So we have to take that into consideration. And finally, we have to take into consideration what we can do with our abutments and our crowns and how we train and modify the soft tissue. So we're going to talk about a little bit about all that. So going back to my patient here, this is tooth number 9. So soft tissue, once again, looks great. I showed you the CBCT on it earlier. Here's the bone. He has a facial plate. So what we're going to do in this situation, it's go time. We're going to take out the tooth and we're going to put an implant in. So we want to atraumatically remove the tooth, and we did not reflect the flat. And remember, we didn't reflect the flat because if you do, you're going to lose 2 millimeters of vertical height. You're going to lose anywhere from 2 to 4.5 millimeters of horizontal width. So we don't reflect flaps. The other thing is we also don't want to lose our papilla. So we're going to atraumatically remove that tooth. The tooth had a crown on it, so we don't need to use the lab to make us a new crown. We'll just use this one. We'll just modify his existing crown. We'll cut a hole in the cingulum of the tooth. And why do we cut a hole in the cingulum? Well, that actually leads us into where the proper position of an implant should be. That's going to be the 3-2 rule. And what is the 3-2 rule? 3-2 rule means that you're going to place your implant 3 millimeters apical to the gingival margins of the adjacent teeth, and you're going to place it 2 millimeters lingual to the facial plate. So that essentially sticks you right in the cingulum. So that's why that's what gives us our screw access, so that we can make it a screw retained provisional. As you can see, this is the tooth in place. And then just to top things off, to minimize any extra shrinkage, because if you guys have taken my hard and soft tissue classes before, you would have heard me say that even with perfect socket grafting, you're still going to, on average, lose about 20% of your buccal lingual bone width. So that's why, on top of all these aesthetic cases, we'll also add a little bit of soft tissue. Here we can see how the soft tissue is healed very, very nicely. Pretty simple here. So here we are pre-treatment and 3 years later. Some of you guys are probably going, who keeps a patient in a provisional for 3 years? Well, once again, this is a personal friend of mine. So he actually procrastinated, just never got the final final crown because this works so well for him. So I was able to at least take radiographs. So this is his provisional at the time of placement versus 1 year versus 3 years. You can see the bone levels are completely stable. Once again, when you look at the supporting studies here from Tarnow, do an immediate implant, you graft the gap with bone. We use mineralized cortical bone in this situation. You put a full contour provisional on, you're only going to lose about 0.7 millimeters of crestal bone height. And this situation, I would say it supports that paper. Another one. So in a situation like this, I told you guys earlier, generally speaking, if a patient has, recession, you generally don't do an immediate implant, and which I stick to, by the way. This is an older case, but when you look at the CBCT, you're going to see that this has a facial plate and a really nice lingual plate as well. She has a super low lip line, and honestly, that's probably what dictated our thinking more than anything. If she had a high lip line, I would have told her just to stage the case. But here we have our atraumatic tooth removal, and then the benefit of using a CBCT. By the way, I use a Planmeca Pro Max. I've had it since 2005. I think it's one of the older ones that's still in use for these types of functions. But anyway, great machine, worth every penny. It'll last you forever. They make those things like tanks, so you'll never have to have any trouble with it. So here we've got tooth number 8. What I like using the CBCT for, in addition to checking out facial plates, for surgery, we also use them to fabricate surgical guides, and you can use them with just about any implant company you want to. And it's kind of nice because it takes all the guesswork out of it. So if I'm recommending that you take out teeth without a flap, if you can put your implant in without a flap, that's even sweeter. So in this situation, you can do that. Here's our implant going in straight through the guide, and it's got depth gauges on it. I can always show you guys how that works at a later time. And then you're just going to use just a clear plastic matrix to fabricate a provisional restoration. And obviously the matrix was made before we took the tooth out. You can see the access hole in the cingulum of the tooth because that's where we place the implant. So that's another question, is if you take out a front tooth, how do you get the implant to follow the 3-tooth rule and get it into the cingulum area? Well, that's the purpose of the surgical guide, is to help guide you there. Because otherwise it is kind of hard to visualize. The natural tendency is to place the implant directly underneath the incisal edge, like you're just following the socket. But the proper position is going to be to the lingual, and we're going to walk you through that again some more. So here's our provisional restoration, and we're just going to screw that in. And once again, see that recession. So what are we going to do about that? We're going to add a little bit of soft tissue and pull it down. That's what we're doing here. Bone looks awesome. This is a few months afterwards. Now the provisional is getting kind of dingy, but oral hygiene could probably be a lot better. But at any rate, you can see what the purpose of a full contour provisional is supposed to do whenever you do an immediate implant. So complications with anterior teeth. I'm going back to this photo here. I mean, I don't know too many of us that would be comfortable treating something like this if it came into our office, or worse yet, if we did this and this was our patient and that was our implant. I don't know that any of us approach these cases with a whole lot of confidence usually. Certainly we can sit around online and talk about solutions, but ultimately what I want to train people to do is how to avoid these types of situations, because they are easily avoided, especially with the implants. I always tell people, it's not like doing a root canal where if you perforate the root, you got to take the tooth out or, you're done. In a situation like this, if you put your implant in the wrong place, if you can't redirect it, you can just choose to leave it out and start over and live to fight another day. So that's one thing about implants. It really tests your ego Let's put it that way. So who are the most difficult patients? So if you're evaluating a patient for the first time and they say, hey, I've got a tooth that needs to come out and I want an implant, how do you, as a dentist, tell if it's a hard case or an easy case. And I'm going to teach you that. So this tooth comes in, it's tooth number 9. Clearly, you have a horizontal root fracture. Now, also, if you look at the radiograph, you have bone loss on the distal associated with the fracture, and then you have a gigantic vertical periodontal defect. So that already tells you it's probably not going to be an easy case. Now, let's just say you're a dentist and you don't even do surgery. It's not even your problem. But how do you know that's going to be a hard case just looking at the clinical photo? Well, the things you're going to look at the clinical photo is that the tooth is a very long tapered tooth. You want, if for an easy case, you want a short fat tooth, short square tooth. Tall skinny teeth are hard. Why are they hard? Because they have big papilla. And big papilla are prone to black triangles like you already have here. So this is why, if you're new to this, new to any of these concepts that we're talking about, pick you a nice short square tooth. That's what you're going to want to do. Don't pick this one. How tall should papilla be? I know we talk a lot in dentistry about white aesthetics. We always talk about the shade of teeth and the hue, chroma, and value, and all that stuff. And we talk about the gingival contours, but how tall are papillas supposed to be? Papilla are supposed to be 40% of the length of the full length of the tooth. That's how tall they're supposed to be as a general guideline. This is from Stephen Chu. So what screams danger in this case is that we have a long tapered tooth and big papilla. You already have a black triangle and you have a high smile line. High smile line, by the way, is not defined by whether or not you can see the gingival margin. It's defined by whether or not you can see the papilla. And the reason that's important is because the papilla show about 87 to 100% of the time in the average population whenever you smile. So all implant procedures, when it comes to hopeless teeth, start with an atraumatic extraction. So atraumatic, our definition of this is we're not tearing up the adjacent papilla or any of the soft tissue, and we're not breaking a facial plate that wasn't already broken before. So when you look at it from the facial view, because we have a long tapered tooth, you're going to notice that facial tissue shrinks immediately. Second thing you're going to notice is that papilla, very, very flabby, very unstable right off the bat. So we have to think about grafting that site and not putting an implant in at the same time. Don't have a facial plate. I don't need a CBC to show us that, because you can use your probe or whatever. But even beforehand, I already know that I did not want to do, with all the bone loss around the tooth, I did not want to do an immediate implant. What are we going to do to support the soft tissue, though? This is a mineralized cortical socket graft, so it's going to preserve the socket. But what do we do to preserve the soft tissue? This is a little bit more challenging. So for this, we selected a tuberosity graft, and we call it a little bit of a composite graft, or what we call a modified socket seal graft, in which case we take this chunk of tissue and bone from the maxillary tuberosity, and you're going to notice half of it's bone and the other half of it's soft tissue. And all I do is we plug the coronal part of the socket with this graft. And I'm going to show you guys this case over and over because there's so many different nuances to it. Then you just secure it with a suture and let it heal up. Now, in my short time today, I don't get to show you guys everything, but when you do your surgical planning, this is with your CBCT, and you can use whatever software you want to. It doesn't really matter. But look at the 3-2 rule in action on the CBCT. So the upper left hand side of your screen, look where number 8 is compared to where number 9 is going to be. So number 8, you can see, once again, front teeth, very prone to very thin facial plates, if not adhesance. So when we do our implant, we want that thing 2 millimeters to the lingual, and we want to bury it 3 millimeters below the three gingival margins of the adjacent teeth. This is a flapless implant surgery because we use a surgical guide. That's what we're doing here. Here, with the implant placed, you can see that the periodontal defects are totally closed and healed up. Everything's looking good. And then 4 months later, we're going to let that heal up. We're going to put a provisional restoration on. Now, what's wrong with this picture? Well, we lost the central papilla, so that's not good. But I'm not worried. Now, why am I not worried? Well, fortunately, we do have data and research on our side here. So we've done everything we can, once we took the tooth out. We preserved the bone, we preserved the soft tissue, but it still shrunk on us. It shrunk on us because it's a long tapered tooth, and that's bad. But we're not worried, because what we're going to do is look at the science, and we know that if you just do nothing, don't do anything, put away the scalpel, put away the drills and everything else, and if you just let it heal up, we know that the papilla will in the presence of good oral hygiene, the papilla will spontaneously increase in size 0.375 millimeters, which is half a millimeter, which for a papilla is a whole lot. So when you look at the pre-op compared to the 4-month after the provisional to the final restoration, you're going to notice that black triangle is about the same size before as it is after, and we got ourselves a pretty decent result. So to summarize here, the reason that we have this 3-2 rule is that when you look at the studies, this is Small and Tar now back in 2000, so I know it's 22 years ago. But if you look at this sites on front teeth, 80% of all sites get facial recession, but the majority of the time it's going to happen within 3 months. So you can, as a general rule, expect about 1 millimeter of recession from the time that you place the final restoration or connect the abutment for the first time. That's 80% of the time. So that's why we overcorrect everything and just really try to, freak out and overcorrect everything to the lingual if we can. The average recession, this is from Uli Grunder, the same guy who talked about the papilla increasing by 0.375 millimeters after a year. He also showed that the average recession on the facial surface is about 0.6 millimeters after the first year. So we're all, talking about very similar numbers. Last thing about smiles, though, this is once again from Stephen Chu, very, very skilled prosthodontist. He works with Dennis Tarnow. So in the smile, the papillas show 87 to 100% of the time. I talked to you about that earlier. But these patients, when we look at high, normal, and low smile lines, 10% of patients have really high smile lines. I mean, they show everything. They show more than 4 millimeters of tissue in their high smile or a high E or high aesthetic line. 20% of patients have a low smile line, and 70%, which are considered normal, that's where their lip hits right at the gingival margin. So the papilla height, once again, is generally 40% of the length of the adjacent teeth. So when we're talking about immediate implants, we want to consider immediate implants very carefully. You want to pick the correct implant size. So we're not trying to stick a 5 millimeter diameter implant in these cases. The majority of the time, you're sticking a 4 millimeter implant in or smaller. We talked about the 3-2 rule. Talked about considering guided implant surgery so you don't have to reflect a flap, and also just kinder to the soft tissues, keeps things, especially if we have long tapered teeth, keeps the gingival morphology and architecture a lot more stable. For front teeth, I always recommend doing a provisional restoration first, because that's just going to make your life a lot easier. And consider screw retainer restorations if possible. That way you don't have to mess with a lot of subgingival cement and that type of thing. If you're interested in these cases or something a little bit more along the surgical lines, I do want to remind you, I've posted this on my Instagram as well. We have Dr. Curry Levitt and I do a hard and soft tissue grafting course. It's hands-on at live surgery, hands-on with pig jaws, live surgery with Dr. Levitt, since it's at his office in Las Vegas. We do 16 hours of lecture, lab, and live surgery. So it's really good. $1,195. I think it's the best value in surgical CE. Personally, it's March 4th and 5th in Las Vegas. Fun time to be in Vegas. If you're living in a cold place like I do in Oklahoma, it's a great place to get away for the weekend. So anyway, the link is in my Instagram bio, david.wong.eds, or you can just look at the OR Foundation's website. That's the sponsor. So anyway, check that out. So let's pose a problem to you. So here we have a patient who wants an implant to replace number 8. But the problem is that number 9 is also in deep trouble. So what we've done here is we went ahead and did a ridge augmentation for tooth number 8, and then we did a socket graft for number 9. At the 6th month, you can see the re-entry, and you can see we have a mountain of bone to where we can put 2 implants in. These are 4 diameter implants, and we have a boatload of bone to the facial of it to support the soft tissue. The problem is the soft tissue was supported on the facial, but we lost the papilla between the 2 implants. Now, this is the final restoration. The big question here is, where is the papilla? Because this is where he started. He used to have a pretty big papilla. Now he has no papilla. So what happened? This is what we need to investigate, because when we look at Dennis Tarnow's work, this is a paper back in 2003, he shows this diagram which you have 2 implants, and the bone has this nice, beautiful peak of bone between the 2 implants. Well, in my case that I just showed you, I didn't get that. So we need to look at the prosthetic side of it, the restorative side of it. And if you want, you might want to screenshot this table, because it's going to be very, very valuable and serve you well. You're going to notice that at the very bottom, the distance between 2 implants is typically 3 millimeters, which is what my 2 implants were. And the vertical soft tissue, meaning the papilla height, is only 3.5 millimeters tall. It's not very good. If we would have went implant to ponic, you gain an extra 2 millimeters of papilla height. Tooth to implant's the best or in most commons, because you get 4.5. So tooth to implant is way better, from a soft tissue prognosis than implant next to an implant. So one solution to this problem is that you can do what we call a serial extraction technique. So here we have tooth number 9 that needs to come out. Number 8 also needs to come out, because that crown keeps falling off. And right now it's just temporarily luted on. So we're going to take out number 9, and we're going to put an implant for number 9. This is really important to do one at a time. I'm going to show you why. We're going to take out number 8. We did this, I believe, 2 months later. We did the same thing for number 8. Took out the tooth, put in a implant, grafted the gap, got a grafted gap, and I used a membrane. Okay, so that answers those questions there. We're going to let that heal up 4 months. Now, look what you see. You see the nice, beautiful peak of bone between the 2 implants, as you can see here. Now it looks like the diagram, and now when we restore it, it looks a lot better. Now that's predictability. Okay, that's just doing 1 tooth at a time. It's longer that way, but when you have patients who have small papilla that you're afraid to lose, this is the one easy trick. If you're a beginner or an intermediate surgeon, getting into this, it's one good way to practice this. Now, one thing is the patient had a cement retained restoration. So after a year, the gum tissue got really, really red. And you'll notice that we started getting some crestal bone loss around number 8, because we had some cement there. So when you're cementing these things, refer back to the keys to implants webinar that we did last year. We talked about how to properly cement a crown. So that'll be on there. Abutment selection. I want to talk to you guys about that. 4 factors affecting implant aesthetics. We already talked about existing gingival levels, implant depth. So we have already discussed how recession affects aesthetics. We already talked about implant depth and the 3-2 rule. We talked about responsive tissues to implant procedures, which is where you do serial extraction 1 at a time versus both at the same time, and how your tissues respond to that. Now we got to look at the management of the tissue with the abutment and the crown. So here we have a hopeless number 8, and Adam's going to get on to me. I always run a little bit late lately, so I don't know if I'm talking too slow or not. But number 8. We're going to take the tooth out. We have no facial plate. So no facial plate, no implant. Okay. So we're going to grow back. We're going to grow the bone. Here's the bone growth. And then we're going to put in our implant flap. Okay. So now we've got a nice big fat papilla between the two teeth, between the tooth and the implant. So now the question is, what type of abutment do you choose? Now this is a friend of mine, so I went ahead and made him two abutments. I've got an Atlantis abutment on your left, and then I've got just a stock stainless steel abutment on, or just stock titanium abutment on the right. Which one's better? If you look at the soft tissue, the one on the right's better. It's the stock abutment. Stock abutment's way better because the tissue's lower. And it's going to give you enough room for your crown to seat and displace the tissue perfectly to where it's going to match perfectly with number 9. But everybody says, well, what about the custom abutment? I heard custom abutments were better. Well, custom abutments are better if you're the one who designs them or you have a lab that's knowledgeable in how to design them. The problem is that a lot of labs and a lot of lab technicians and dentists too, they design their custom abutments to look like crown preps, and that's not right. If your custom abutment looks like a crown prep, guess what's going to happen? You're going to have gingival recession whenever you go to cement your crown, or if it's even if it's screw retained, you're going to have some recession. The tissue is going to go up, and the reason that is because you don't have enough room for the tissue. So this is why here's the custom abutment with its provisional restoration, and then here's your stock abutment with its provisional restoration. The soft tissue looks way better when you have enough room for both the abutment and the tissue. The abutment and the crown. So we went with the stock abutment just for kicks and giggles on this one, just to show that you can get great aesthetics with stock abutments if you want to. This is my good friend here at 5 years. And that's prompts me to bring up this formula from my good friend, Dr. Barry Goldenberg. He's a prosthodontist in St. Louis. He says A plus C equals T. What in the heck does that mean? Abutment plus the crown equals the tissue. So you can't have a big abutment in a normal size crown. You want a smaller abutment in order to accommodate the proper sized crown to train the tissue. So that's why you can get this type of a result. Doesn't matter what type of abutment it is. It's all about your knowledge on how the tissues respond to different types of abutment designs. So another case, I'm going to walk you through this. A lot of times you guys, I'll see these types of cases as well, where the implant's placed in a beautiful position, great position here, but you'll notice a skinny little skinny little healing abutment on it. And then the next picture that I'll see usually is with it off, and you'll see that the tissue looks beautiful, it's healthy, but the problem is it's all collapsed in. It's not very big. It's the improper emergence for a central incisor. So what happens here is I'll hear dentists tell me that, the crown looks too big, the tissue blanches. They had to give the patient anesthetic just to get the crown on. And once they got the crown on, the tissue went up. Okay, so that's a pretty common thing that we see. And then I'll take the crown off, and now often it'll look like the one on the left here. Once again, it looks like exactly like a tooth would, which I get it. That's how we're trained. It's kind of a habit, but keep in mind, upper implants, they don't look like teeth. They're supposed to look like what you see on the right, where you have a concave cervical third of that crown on the facial. This is called the critical zone of contour. You want that little reverse S-shaped curve there too. Once again, A plus C equals T. So you need to minimize that part of the abutment to make room enough for make enough room for the crown to preserve the soft tissue. So we took that abutment off, and all I did is I just shaved it down just as a temporary, just to show my doc what it's like. See, this is that customized abutment that looks like a crown prep, and it's not right. So that's why I had to shave it down. And then once we did that, you're going to see that it brings that tissue down. Crown seats much nicer, and we'll, let the patient walk around with this for a few weeks and then get a new abutment on. But this is just a quick modification. As far as abutments and provisionals, this is not my work. This is my buddy Barry Goldenberg, the guy who talks about that A plus C equals T formula. So this is a case he shared with me. This is actually the first time I learned it as well. If you look at tooth number 7, look how big number 7 is. It's gigantic. Gingival contours are improper, too high, etc. And all you have to do, take off the crown, really shave down that abutment. And as you can see, it's a stock abutment, and just remake the crown. And you'll notice that soft tissue will come down, and it looks much nicer than the previous situation. But don't forget, if you can bring the gums down, you can also bring the gums up. So in a situation like this is also from Barry. If you look at implant number 11, this patient usually is referred to a periodontist, or even with the general dentist, they'll want to get their laser out or something and remove that extra soft tissue. You could do it that way, or you can just mark a gingival margin with a indelible pencil or just a regular sterilized pencil, and then take it off. And then all you got to do is just add a little extra material to the cervical portion, and voila! Once you put the provisional back on the stock abutment or custom abutment, that tissue will go back up as you see here. So there's your final. So a lot of times people get too caught up into, whether it's a zirconia abutment or a gold abutment or stock or whatever. You really need to pay more attention to the abutment design more than anything. So play around with that, and I'm sure you'll get better results. So with my last 10 minutes, I've got a little bit of an update for you. Tomorrow, we're going to be talking about soft tissue. Dr. Curry Levitt, Dr. Matt Fine, and we're going to be talking about soft tissue and dental implants, or just soft tissue in general as well. We usually kind of shoot the breeze over a cocktail, and it's going to happen at 7 o'clock Central Time tomorrow, Tuesday, February 8th. Once again, the link is in my bio. It's actually in my stories for today. I put it in there this morning. So if you guys are listening to this webinar and want to log in tomorrow, it's free, totally free. Just get on david.wong.eds, check out my story, and there's a link in my story. But anyway, here's my update. This is going to be for tooth number 7. We're going to talk about immediate extraction, immediate implant, doing it the digital way. Okay. So here we have tooth number 7 that's hopeless. You can see she's got a long tapered tooth, big papilla. I don't like it, but hey, I don't get to choose who's referred to my office. And it's really hard for me to turn people away. So we're going to do a CBCT here. You have to do a CBCT if you're going to do an immediate implant. Non-negotiable. You can't guess at it. Okay. It may work once or twice, and keep in mind, I'm old. I've been doing this for 20 years. So there were definitely times where I did this without CBCTs, but anymore, you cannot do it without a CBCT. When you look at it, you can see the facial lingual width is great. We have a short root, so we can actually engage a lot of native bone with our implant. So this right here, ideal. Okay. Outside of the tooth morphology, which I don't like, the bone situation is awesome. I mean, you got a big target. You follow the 3-2 rule. Looks really, really good. You're going to have good primary stability. So we have an atraumatic extraction. Tall prominent papilla is right after I took out the tooth. Look at the papilla, goes up immediately. So I hate that. So we already pre-planned everything. We're going to go ahead and put our implant in with the surgical guide. This surgical guide was made from Vulcan. This is going to be a BioHorizons implant. One of my favorite surgical guides. We're going to place the implant straight through the guide, and we're going to put it where at 3 millimeters apical to the free gingival margins of the adjacent teeth, 2 millimeters to the length. Okay, that's where this thing needs to go. The Vulcan, what I love about Vulcan is they can already make you a provisional, so I don't have to do it, which is nice, especially when we just pulled a natural tooth that's been endo treated. So before you put this thing on, you might want to test the stability of your implant. We never really could do that in the old days, but now we can. Through a piece of technology that's called the Implant Stability Quotient, or ISQ. It utilizes a concept called resonance frequency analysis to test the stability of our implant. Essentially what it is, it's just a little metal rod that we screw into your implant at the time of placement. And then we send electromagnetic waves through it, vibrates, and we test the stability of it. Safe and easy to use. This is way better than trying to torque test it. You'll hear a lot of people say, I torqued it to 50 Newton centimeters, and then I reverse torqued it, and it withstood reverse torque. So we went ahead and put a provisional on, or we went ahead and loaded it. The problem is that what if it doesn't withstand a reverse torque test? Is that you've just ruin your implant. So in a situation like this, you can actually just use the Ostel machine using ISQ to track stability. Okay, so let me show you how this works. So you have a rod. On the right side, I've got the smart peg or the metal rod that we're going to screw into the implant. It's got a little wand connected to the machine, and you're going to see that the machine is going to kick out a number from 1 to 100. 70 and greater means high stability, means loaded up. 60 to 69 is medium stability, loaded up if you feel like. Anything less than 60, wait. You're going to keep waiting, okay, until it's more stable. So it gives you some objective information to make recommendations. So this is an example. Took out tooth number 9, implant goes in. My ISQ reads 56 and 41. So 56 buccal lingually, and then 41 mesial-distally. That's low stability. That means the bone's soft, or maybe the implant's over prep. Anyway, it's not a good situation. So don't just put your healing cap on and leave it alone. Put the flipper or Essex retainer. You're not going to load it up. But some people are like, yeah, but I had Vulcan already make the temporary crown. Well, who cares? No big deal. So what you're going to do is you're just going to put the temporary crown in, and then you're just going to chop it off at the gingival margin. And now you have what? You have a custom healing abutment, like you see here. So in this situation, this implant was highly stable. So we went ahead and put the Provisional on, and it's prefabricated. You can see that we have that reverse S contour at the cervical third, which means that we're going to have a concave surface. That's the critical zone of contour. You're going to notice that, remember, we pretty much obliterated the whole socket with our implant because it was a pretty short tooth. So we'll graft just a little bit, and then here we're using a little piece of alloderm to cover the rest of the socket. And then we're going to screw in our Provisional at the same time to preserve our hard and soft tissues. And then in the cingulum, you're going to see that purple stuff here. All that is just some PVS impression material. I prefer that over composite because I don't want to have to drill into anything later. And plus, it's behind the tooth, so nobody sees it. So I'll just squirt in some PVS and call it good. That way, when it comes time to do final impressions and all that, all I have to do is reach in there with the Explorer and just pick it out. So this is going to preserve the soft tissue. As you can see here, this is immediately right after placement. This is 4 months later. And then I've got 6 minutes. I'm going to walk you through this. So at this point, you've got to take an accurate impression. And what you're going to do here is you're going to have a lab analog, and you're going to place it in stone, okay? You're going to take your provisional restoration off, and you're going to screw it onto that lab analog. And basically what you're going to do is just take an impression of that cervical half of that provisional, okay? Now, I didn't do a very good job here, but you're going to take your provisional off and stick your impression coping on, okay? Now that's going to leave you a void between your impression coping and where your impression of your provisional was. So you're going to fill that in with some flowable composite. You're going to cure it, and then you're going to take it off. And then you're going to mark which side was the facial. That way, if you're a specialist, that way your restorative dentist knows how to orient it. If you're restoring your own, that way you don't get lost. But this is the custom impression coping. Okay. And this is what displaces the soft tissue while you take your impression, so it doesn't collapse in. So now we're going to just look at how nice and pretty that soft tissue is. That allows you to deliver your final restoration very passively. It's just going to slide right in. Tissues are not going to blanch. Patient is not going to need anesthetic. Soft tissues will be very, very stable. So there you have it. There's your final restoration. There's your before and there's your after. But that's kind of how it's done in a nutshell. I've got 5 minutes left. So once again, if you want to learn more about this and kind of more of a hands-on interactive manner between me and Dr. Levitt, give us a buzz. Once again, it's a 2-day course, $1,195. Link is in my Instagram bio. And if you can't be there March 4th and 5th, hope you guys can be at Thrive Live. I'll also be speaking there, giving 2 talks. One is going to be on grafting, but it's just going to be a 1-hour lecture. The other one's going to be more of a practice development thing. It's basically going to be me talking about case presentation, how I communicate with patients, how I get my team ready, and how we, how we've created policies and systems in the office to help, get patients, towards yes, especially with these implant cases. So that being said, thank you guys for your attention, and we'll just open up a few questions and hope to see you guys in person sometime.
Awesome. Thank you, Dr. Wong. Got a couple minutes left and a couple questions. So if anyone does have questions, feel free to add them to the Q&A or chat. First one came in relatively early, and I know you touched on it, but just a quick review of the 3-2 rule.
Yeah, the 3-2 rule is where you place the implant 3 millimeters apical to the free gingival margins of the adjacent teeth. So a lot of times people don't bury it deep enough. So if you want to bury it 3 millimeters apical, now you can go 4, some people go 5, but at least 3. Otherwise, you're not going to have enough room for restorative. The 2 is 2 millimeters lingual to the facial plate. That way you have your implant coming out the cingulum of an anterior tooth so that you can deliver a screw retained restoration.
What's the earliest age you would consider doing immediate implants?
Earliest age for me, typically anymore, I go, 20 years old for a male, 18 for a female. But honestly, I proceed with caution, because kids these days, they don't stop growing for a lot longer than they did, 30, 40 years ago. So it's a little bit different. But I would say generally 20 for male, 18 for female.
How do you pick the size of the implant lengthwise and widthwise for immediate implant?
For me, it's easy. Lengthwise, I always go anywhere between 10 to 15 millimeters, somewhere in there, as long as whatever I get gives me the best stability. From a diameter perspective, I always stick, for a central incisor as an example, I'm always between 3.5 and low 4. So I'd say 3.5 to 4.2 is an average diameter. For a lateral, I almost always use either a 3.0 or a 3.5 diameter.
All right. Someone's asking about access for your course tomorrow. Is that on your Instagram?
Yeah. It's just go to Instagram. It's david.wong.dds, and then just click on my story. There's a link that you can click, and then you can just register, and it'll take you about 20 seconds.
Perfect. Well, I am not seeing any additional questions. So contrary to your point earlier, we wrapped right on time.
Look at that, man. I started talking a little bit faster. I felt bad last time. I went like 20 minutes overboard. So
it's all good. All good content.
Good.
Cool.
Well, everybody, thank you so much. I'll see you guys either live or online at some point. So thank you.
Absolutely. We did record tonight's webinar, so we will shoot that out in the next week or so via email. And then if you want to see any future Henry Schein webinars, visit henryscheindental.com/webinars for our upcoming schedule. Hope you all can make it out to Thrive Live in Vegas in April. See you there. Have a great night.
Bye, guys.